Okay, so today we're going to be going over NG tube insertion and then med admin through the NG tube. So to start, the first step is to make sure that you have an order for NG tube insertion and that it's appropriate for your patient and that you understand why they're getting it and what they're needing it for. It's also helpful at the same time as you check or obtain the order for the NG tube insertion to also get that requisition or order for chest x-ray so that we can confirm placement once it's in. So we do have an order for our patient, Chris here. So we just, it says insert NG tube now for meds and nutrition, chest x-ray to confirm NG placement afterwards. So that's great, we have an order, and I'm just going to show this sagittal view model sort of before we go ahead and insert the NG tube. Because it's kind of nice to see what's actually happening in your patient's body when you insert it. So we know because of the name, it's going to go via the nose. It's a nasogastric tube, right? So it's going to go from the nose into the stomach. So that's kind of the path it's going to take down the esophagus. So a couple of things to note is when you do insert the tube, it's going to at a certain point hit the back of the nasopharynx there, and you'll actually feel that, just sort of a little bit of resistance, and that's where we're going to want the tube then to change its direction a little bit and go straight down, right? And you can see that pretty obviously. So it is helpful when you're doing this on a patient to insert with their head sort of in a neutral position like the model is right now, and then when you do reach the back of that nasopharynx, to get them to tilt their head forward towards their chest. It just helps guide it through the esophagus a little bit easier. We won't be doing that today because our model sort of has his head position predetermined a little bit, but just so you know why you would be asking your patient to do that, to help facilitate that movement through the esophagus. The next thing I'm just going to show and tell is some different types of nasogastric tubes that you may encounter in facilities so that you're prepared. So this one is just a straight tube. It has a blue end on it. There's not too much exciting with it. This one comes in different Frenches, most commonly 14, but it does have a 16 French. And with these nasogastric tubes, the French is intuitive, that the larger the number, the larger the bore. So 16 would be larger than 14, for example. So this one's pretty basic. It's just got some pre-marked markings on it throughout the tube, and then its holes are at the bottom. So this is the part that would hang out of the patient. This is the part that will go in their stomach. This is an older tube that the WRHA is sort of moving away from right now because there are some nicer tubes for your patient out there now that they're supplying, and we'll get into that. But you may still see this one, so it's just nice to be familiar with the different types. So we'll just put this one aside for now. Another common tube now, the popular tube for feeding, and even it can be used for medication administration, is this one. And the brand is Kangaroo. That doesn't matter so much. You'll hear it may be referred to as a small bore feeding tube because it's a lot narrower of a tube. This one in particular is a small French, but they also range in the sizes that you can choose. So you can choose a larger French for this one as well. And this one is kind of neat and special because of a couple things. It has a weighted tip at the bottom. That's what those silver weights are. And it also has a self-lubricating or a lubricating technology that you can activate, so you don't necessarily need to apply the lubrication yourself, which we'll go over in a little bit. This one gets lubricated by holding it in a cup of water for at least 5 seconds, and you can hold it for a little bit longer than that, and then it lubes that end of the tube for easier insertion. Though if you don't get the sense that it's lubed it enough, you can always add more lubricant, water-based lubricant to that as well. The other kind of interesting thing about this tube is that it has a stylet inside, or a guide wire, which makes the tube a little bit stiffer for insertion. And this guide wire is then removed once the x-ray has confirmed that it's in fact in the stomach, so that it's not staying in the patient with the guide wire in. So when you do insert this type of tube, you would do the same process for insertion that we'll go over right away, and then you would get your x-ray to confirm placement, and then once placement is confirmed, you would instill water into the tube to lubricate the inner part of the tube, and then that facilitates removing of the guide wire. And then you would just discard that guide wire, and then the tube would stay in. So that's this one. It can be used for feeding and for meds, like I said, but because of the size of them, they do sometimes clog a little bit easier than the other types. But it's just good to know that you may see this one as well. Just one other thing about this one, because it's small bore feeding tube, or a small bore feeding tube, you may sometimes see the acronym SBFT, and I would encourage or caution you from not using that acronym and actually writing it out, because SBFT used to mean small bowel feeding tube, and that's a different thing, as you guys would understand. That would be a feeding tube that's going all the way into the small bowel, so it has different sort of set of procedures around it, including that nursing does not insert small bowel feeding tubes. So just to be very clear about the product that the patient has in them, or where that product is ending up, you want to be clear that it's a nasogastric tube. Whether it's small bore or not, you can mention, but just not using that acronym SBFT. So I'll put this one aside, and we'll move on. So this one, the title of it is called the Salem Sump, but I kind of like to call it the silicone or large bore feeding tube. You may hear it kind of called any of those things. Again, it comes with different Frenches or sizes of diameters. So this one is a 12 French. And I'll just pull it out so you can see it. So this is how it comes out of its package, or how it comes in its package. It has this piece already connected to it, which we will use later on in our demonstrations. We'll show you this is actually just for decompression or suctioning. So right now I'm going to remove it because we don't actually need it at this time. And you can probably tell even just how it's flopping. It's a nice soft tube. So it's that silicone. This one seems like it would be really, really nice for the patient, or nicer at least for the patient to have inside their body. It's a little bit softer, less stiff. It does, however, make it, just a little bit more challenging for the person putting it in, but it does go in, and you can do it. You're just going to have to lubricate that end again, and this one doesn't have that technology of that it self-lubricates, so you would just lubricate it with the water-based jelly, which we'll go over. So it's got these ports at the top. You can adjust the width of the port. So right now they're both quite wide, you can see. So we can cap off one for sure, and this wider one, when we do want to use the tube, or once the tube is in, we can actually put this cap on, just the one big one, and you can see that it still has a hole in the top, and that's convenient for our enteral feeding syringes that have that small slip tip top, so that would get inserted into here. This is a big push and move, or there is a big push and move right now for enteral feeding supplies, that we'd like to all sort of be on the same page with the purple supplies for anything enteral, so that it mitigates that risk of confusing IV supplies with enteral feeding supplies. So you will probably start to see that more and more rolling out in facilities. So this purple type of supply will become more and more common, hopefully over time, to limit any sort of confusion. But this is kind of nice that you can use a slip tip in here to instill fluid or to remove aspirate. So we'll get started with that. We're going to instill a Salem Sump So this is that large bore one. This can be used for decompression, as you saw with that adapter, and we'll show you that after. But this one is also has an off-label use of giving medications and feeding through. So this one's actually quite nice, kind of all-in-one tube for us right now. So one of the things with preparing nasogastric tube insertion, of course you want to explain it to your patient. Be quite traumatic experience, or could be a traumatic experience for them, as you can probably imagine a tube going in through your nose. So you just kind of want to explain to them in terms that they understand and the level of information that they want. What you're doing, what the procedure will be like. It's not going to be a comfortable procedure, so you would want to mention that to them, that this is going to be uncomfortable, but once the tube is in, it does kind of settle and it's less uncomfortable once it's in. You'd want to explain that they'll be going for an x-ray shortly after to confirm placement, and you'd want to explain to them the indications, why you're putting this tube in, what they're needing it for, so kind of help get them on board with it. So we've done that already with our patient. We have our tube, we have our syringe, our enteral feeding syringe that fits our tube. It's a good idea to grab a blue pad or towels because it can become kind of messy. And this is helpful. You could rest it on the patient's lap or sort of on their chest, depending on the situation that you're in. The other things that are important to have before you start, it's helpful to have a safety pin because when we are done putting it in, to secure it to the patient's gown, we usually will wrap a piece of tape around our tube and then pin it through the tape onto their gown. So it just helps hold it in place a little better. You need to have pH strips or pH paper, and this is to test the pH of the gastric aspirates, which you'll know now that we want to be between 1 and 4 for gastric contents. As well as a measuring tape is a necessity, because once that tube is in, even before x-ray, if we use our other evidence to see that it's in, we'll actually want to measure the tube from the nares to the end of the tube before they go for x-ray, because if when they come back from x-ray it's confirmed that it was in fact in, you'd want to know that that hasn't migrated at all in transport to x-ray or on the way back, that kind of thing. So we'll definitely want to measure it. So having a measuring tape, and these can be, this one is a nice reusable one that can be cleaned off. But you would want to leave it at the patient's bedside. Lubricating jelly, you may hear it called Muco, that's just a brand, but a water-based lubricant you'd want for sure, and that's to lube our tube again before we insert. Definitely gloves we'll want, because we will likely be coming into contact with, hopefully be coming into contact with body fluids, his gastric contents. A permanent marker is a good idea. A lot of people like to use that to just initially mark the tube after we do our sort of crude measurement, and I'll show you what I mean by that. Another good idea is a pen light or some sort of flashlight, and a tongue depressor. This is helpful, and we won't necessarily go over this with our Jake doll here, but if the tube does happen to, when it goes through the nose, it can sometimes coil up in the mouth, and you may not notice it immediately, so it is helpful to just kind of check to make sure that it's not collecting and coiling in that person's mouth. So a tongue depressor and a flashlight is not a bad idea. A cup of water, if indicated, is not a bad idea either, because it helps the patient actually swallow that tube down. As we showed in that sagittal plane, you're actually wanting them to basically ingest that tube into their digestive tract. So helping them swallow it down can make it a little bit more comfortable. So having a cup of water with a straw for them to hold is not a bad idea. Having another buddy with you is also not a bad idea, just to help with the dexterity of holding it once it's in, or holding the cup of water for them. Definitely don't be shy to ask somebody for help with this. It can be a lot of different steps. Another necessity is having tape nearby and ready to go for securing it either to their nose or, like we talked about, for the gown. Another way to secure the tube to the nose is with something like this. These they're available on most wards where you'd be inserting NGs. There's sort of a tape that goes over the bridge of the nose and then sticks there, and then it has a clip on the bottom that you just close over the tube once it's in. So those can be pretty handy. I find sometimes they don't stick well to all skin types. If the person's a little bit more oily, that can be a little bit difficult, so you end up using tape anyways. But just so you know, it's out there and available for you. So we are going to begin. Always first, we're going to wash our hands. We've again introduced ourselves to the patient, checked the order, explained the procedure to them. They are on board with this, and we are ready to go. So I'm going to first I'll have my tube ready to go. I'll just go over the measuring process or procedure. So we're going to start with the end of the tube, because that's how we're going to start inserting it, with this end. And how you measure is from the nose to the ear to about the xiphoid process. And you may hear that referred to as the NEX method. So we'll start at the tip of the nose, and you sort of just bring it back to their ear, and then bring it down to their xiphoid. And I like to go a little bit further than that, even just to give myself a little bit of extra room. And you'll see a lot of people will either mark this with indelible ink, just so we know where we're inserting up to roughly based on our measurement, our crude measurement, as I say. So we're just going to mark our tube there. That's about where we want to go up to. At this point, I'd probably give my patient the water, ask them to take a couple sips of it. I'm going to apply gloves, and we're going to lubricate the end of our tube here. So you just kind of want to get it nice and lubed up so that insertion is easier on the patient, and it just slides down the esophagus a little bit more readily. Okay, this can just go in the garbage. It's not a bad idea to make sure your caps are on your tube, because if and when you do hit gastric contents, it may come back up, and to have your syringe ready to go as well. Okay, so you'd want your patient in a high Fowler's position for this. That's maybe obvious because they're going to be swallowing, right, the tube and or water. So high Fowler's, and then like I said, this model kind of drops his head regardless, but at a certain point, you're actually, once you get to that nasopharynx, you're actually going to ask them if they can, or it's not contraindicated, to drop their head towards their chest. So you want to select a nair. Maybe the patient has a preference. Maybe you can see obvious polyps or something that would be making one more optimal than the other. So make your selection however is best for the patient and you, and then you're just going to go ahead and insert. So this is where I usually tell my patient, swallow, 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 swallow. They'd be holding the cup of water. This is really uncomfortable, again, for the patient, like we said earlier. This makes you want to gag, as you probably imagine. A lot of times people do gag, they kind of sputter, but if they can just kind of keep that swallowing down and you're encouraging them, can make it a little bit easier on them. So as I mentioned, you would want to tape this right away, or this is where having a buddy, someone to help you out, is a good idea, because they can maybe hold the tube before you tape it, just to confirm while you're checking the gastric contents. So I'll just let his head rest. I just taped it for now. So Chris, I'm just going to check to make sure we're in the right spot by pulling back some gastric contents here. So I got some gastric contents. You don't want to take too much. He just kind of gave it all at once there. A couple mLs is just fine, but what I do want to show, sort of dramatize here, is that that's a nice, obvious, grassy green. I'll hold it up against a white background. Nice, obvious, grassy green colored gastric contents, and that's a good sign. That's a good sign that we're in the stomach. And we'll undo this. We're just going to close it off. And we know it's secure, and at this point I would be telling the patient, I know it's a little bit uncomfortable still, but please refrain from pulling that tube out. And we're just gonna confirm it here, and then we're also gonna send you for that x-ray that we talked about. So we're just gonna tear that off. And your pH strips have that legend or indicator on it, so we can kind of have that nearby. This is not a bad idea to do over a med cup or a towel, etc. So we're just going to let that react. And it looks like he is in fact a 4, so perfect. We are, I think, just based on the color and our pH, we are very much likely in the stomach. Other things you want to note at this point is the patient coughing a lot. Is there respiratory characteristics, have they changed at all? That would be an indicator that it's possibly sitting in the lungs and not in the stomach as we wish or want it to be. And also, like I said, I could just show this for. So we're using kind of a couple different indicators that it's in the right place. We will take our, just to show this how it works here, we'll put it on the bridge of the nose, and we will, it doesn't stick very well to him either, and we will close. Oh, it stuck well, actually. That's pretty good. And we'll close the tube or the clamp around the tube. So at this point, once we've sort of secured it and have that crude confirmation, we're going to measure it with our measuring tape. So this is where from the tip of the nair, or the tip of the tube here, to the base of the tube. And you'll want to write down this measurement pretty well right away. So it is about 25.5 inches, or about 65 centimeters. You can just re-measure that to confirm. And we're going to mark that down and note that. Yeah, so we got about the same again. So we will now send you, Chris, for an x-ray, and that will, because the tubes are all radio-opaque, so that means they do show up on x-ray, even though this looks like a nice clear tube. It's got a line through it that will actually show up on x-ray, and you want to see it going past the diaphragm into the stomach. So that would be read by your physician or radiologist. And then once you have placement confirmed, you can go ahead and use this for the interventions that we talked about. Say it's decompression or feeding or med administration, then you can go ahead and do that. But before every time you use it, you will want to reconfirm placement because, like I said, these tubes can migrate easily. He's doing things that you wouldn't want that to have migrated a couple centimeters and you didn't check. Check pH and check the measurement. You don't want to miss that. That it's misplaced. So at this point too, definitely before he goes for x-ray, I no longer need my gloves, so I'll just throw those out, clean my hands, and we can put a piece of tape. This is sort of what I was talking about before. He's not wearing a gown, but if he were, it's kind of helpful to put a piece of tape on here and then just stab through the tape and then put it on pin it to the gown. So it gives it a little bit of slack there, that it's not always dangling down and pulling. And so you did great, Chris. We're going to send you for x-ray. I think it's in, but we'll confirm it via x-ray. If you have any questions, let me know. This is where I would also go and document the time and the date that I inserted this NG tube, the reason for it, explained procedure to patient. We used a 12 French Salem sump large bore tube. We did see grassy green gastric contents, and they tested with a pH of 4. I'd want to note that measurement of 65 centimeters from nair to tip, so that potentially it might be me, the next person who measures it, but just to communicate across different staff who come on that they know that tube is in place or not. And maybe you'd want to mention awaiting x-ray to confirm placement. We'll discuss with physician once x-ray comes back. So that's pretty much it for insertion.